Welcome to Surviving Society's collaborative series with the Centre on the Dynamics of Ethnicity, based at the University of Manchester, also known as CODE. In these episodes, we explore the facts and evidence produced through the Centre's leading research. We ask how changing patterns of inequalities relating to the ways in which ethnic identities are perceived, acted upon and experienced in Britain. Across the series, we focus on policy and debates around ethnic diversity, integration, immigration and inequality. I'm currently joined by James Nazroo, who is Professor of Sociology and one of the Associate Directors of CODE. CODE being the Centre on the Dynamics of Ethnicity at the University of Manchester. James Nazroo is someone who I have cited and or written about since I was about 18. James's scholarship is so important to sociology and in particular medical sociology. It's featured in GCSE and A-level textbooks, obviously is a core part of hopefully undergraduate and postgraduate research in sociology. It's just great to finally meet you. You've done so much, quite overwhelming to be honest, like thinking about 17, 18-year-old Chantel writing out your name and thinking, this is an interesting name. I like the Z in it. Yeah. But yeah, I was reading a bit about your biography, James, and I didn't realise that you were a qualified doctor.
Yeah, so I did well at school. Mm-hmm. Going to medical school was one of the options. I was good at sciences and stuff like that. And so that was one of the options, and it was something that I wanted to do. So I guess this is in the late 70s. I kind of orientated my choices towards going to medical school. I was very fortunate to get a place. At the time, places in medical school, they probably still are, was very, very competitive. But people with ethnic minority names were discriminated against. It was well recorded a few years later. But anyway, I got into medical school. I went to medical school in 1980. And I don't know if you know, but in 1980, a report on inequalities in health was published. In 1979, in fact, I think it was published, the Black Report. And this was the first major inquiry into inequalities in health. It was suppressed by the then Thatcher government, but nevertheless it got onto the curriculum. And so during my first 2 years at medical school, this was one of the things I was taught. The other thing I was taught was an inquiry into improvements in health and life expectancy and the role of public health in that, done by Thomas McEwen. And both of those reports pointed to the lack of effectiveness of modern medicine, which is kind of really interesting when you think about how we think about medicine, that much of the improvements in health had happened before any effective medical interventions were in place, and inequalities in health were obviously being driven by social and economic inequalities. That was the primary focus of the Black Report. And so I became a little bit disillusioned with medicine. I also became a little bit disillusioned because it's an incredibly hierarchical, patriarchal organisation and remains so. And so, I became a bit disillusioned and became very interested in sociology. I was taught sociology in medical school. And then
that's incredible. This is what I mean, like how you came to sociology and the time in which this was. You must have had an incredible mentor, like people around you, like helping you to develop a sociological imagination whilst being a scientist.
Yeah, so what that led to, in effect, I did well at medical school, and so I was given an option of a year out. So there is this option of a year out to study another subject, and there was this fantastic lecturer at Middlesex Hospital who offered a degree in medical sociology. His name's Graham Scambler, just to name check him. And he was that person. He was the person who made me think seriously about sociology, think differently about society, the ways in which inequalities operated within society. And that then led me back to medical school. I finished my degree. I worked for a few years, but then I started a master's course in sociology. And then I went on to do a PhD and research jobs and so on, and became a sociologist concerned with the question of inequality and how inequality impacts on the ultimate outcome, how long we live.
James, that's incredible. Thank you so much for sharing that kind of personal, professional and political narrative of how you came to medical sociology. I'm going to fast forward now to 2020. So you're a qualified doctor, you're also a medical sociologist, you're someone that has been for a long time now concerned with ethnic disparities in health, public health and well-being. March 2020, the UK government, global governments announce a lockdown and that we're in a global pandemic. What are you thinking straight away with all those hats on? What were you thinking?
Yeah. So I've been studying ethnic inequalities in health for 30 years, maybe close to 30 years when that happened, not quite 30 years when that happened. And as part of that, my work had increasingly focused on the drivers of ethnic inequalities in socioeconomic circumstances, basically racism. So my work increasingly focused on the question of racism and how racism was shaping the health of ethnic minority people. At the time of the global pandemic, when it began, I think what was immediately noteworthy was that public health were taking a view that this was a highly infectious, highly dangerous disease that was going to kill everybody. And that's what drove the public health response. I also do a lot of work on aging. So I do two areas where they relate, aging and ethnicity. And what immediately struck me, of course, was that the people who are going to be vulnerable would be older and poorer people. But the public health response ignored that. We forget this now, but it did. The public health response ignored that and said we're all at risk. And then two things happened. One is the statistics began to show the large numbers of older people who were dying. And the need to do something about that, though we were very ineffective in addressing that problem. And the other thing that happened was that media began to report on the colour of the people who were dying. And so we began to see in tabloids and in broadsheets and in popular journals pictures of ethnic minority nurses, doctors, care workers dying. And at that time, the vast majority, maybe I'm exaggerating, but certainly a very large proportion of healthcare workers who died were ethnic minority, much more than is their representation in the workforce. And at that point, I and a colleague, Laia Becares, began to think about how we might mobilise evidence to expose the nature of this. And I had a conversation with the Guardian journalist about the work they were doing. We agreed to try and adapt some of their methods to look at area differences in risk of death and how area differences in risk of death related to the ethnic composition of areas. Those were the only data that were available at the time. And we did that, and we published the papers eventually. And of course, the Guardian did their piece of work as well, and more evidence began to take place. But of course, Laia and I centred racism as the driver of the factors that produce risk for ethnic minority people, whether it's the ways in which people are placed in the workforce, whether it's the kind of areas in which they live, the kind of housing they have, and so on. Also, other health risks that they have, which ultimately are driven by socioeconomic inequalities and racism. So we were placing it in a field of racism. At the same time, there was lots of campaigning going on saying, do something about this, do something about this. So the ring of steel around care homes, which never really existed for older people. What is being done for ethnic minority people? And essentially what was being done was ethnic minority people were being blamed for their high risk. You're going to the mosque, you're going to the temple, even though there's lockdown. Let's lock down Manchester because it has a large ethnic minority community, in effect, just before Ramadan, and so on. Final step of this story is that, and maybe I shouldn't say this, but the Ethnicity SAGE working group were tasked to find what it was that government was doing that was making a difference to ethnic differences in mortality rates. When I was involved in discussions around that, I was basically astounded because it was clear government had done nothing. So what was the motive behind this? And then the other little bit of backdrop behind this, of course, was the Commission for Race and Ethnic Disparities, which was going on at the same time, or began, I think, in the autumn of 2020, which was informally tasked to make racism disappear. To say that racism,
about the Seal report?
Yeah, the Seal report. Yeah. To say that racism wasn't the cause of the inequalities that we were seeing. So all this kind of anti-racism agenda was going on. And maybe one final thing to say about this is that, of course, this was a big break from however much we feel that the Conservative government and the coalition government that preceded it were not really concerned with any inequality. There was a big break that happened because both David Cameron and Theresa May did talk about ethnic disparities, and also talked about discrimination. They maybe didn't use the word racism, but they talked about discrimination and ethnic disparities. The government that took over from Theresa May basically set about not only pretending inequalities don't exist, but also that discrimination and racism don't exist.
And James, thank you so much. That was such a clear summary of the racism that has been central to the COVID-19 response here in the United Kingdom. I think that thinking about the trajectory between David Cameron, Theresa May, and then Boris Johnson, and now Liz Truss, then Rishi Sunak, that move, if we were gonna use a social drive, or if we're going to use a process to really signify how sharply the government moved to the right or to the far right, that I think this is such a really good descriptor, as in how we then do not discuss racism. We say it does not exist. That's essentially what you're saying, what you're using health to describe. Yeah.
I mean, the reassuring thing, not overly reassuring, but the reassuring thing, of course, is that the campaign reaction to the Sewell report has put racism back at the forefront of discussions. So in a sense, it, not in terms of government action, but in terms of broader discourse, it did backfire.
I just want to read a couple of the statements from the report that you did with Laia Becares, Ethnic Inequalities in COVID-19 Mortality, a Consequence of Persistent Racism. So one of the key points you have here is ethnic minority people experience a much higher risk of COVID-19 related death, a stark inequality that impacts all ethnic minority groups, including white majority groups such as Gypsies and Irish travellers. Local authorities with higher proportions of ethnic minority residents are likely to have higher numbers of COVID-19 related deaths. Ethnic minorities are also at increased risk of complications and mortality post-COVID-19 infection. Greater risk of serious illness of COVID-19 is more likely the result of pre-existing social and economic inequalities manifesting in the form of particular chronic illnesses. There is no evidence for genetic or genetically related factors. Biological factors underlying this increased risk, including vitamin D deficiency. And then finally, unless racism is understood as a key driver of the inequalities which increase the chances of exposure to and mortality from COVID-19, government and public sector policy responses to the coronavirus pandemic risk further increasing ethnic inequalities in the UK. Yeah. Wow.
Just one slight correction there.
Go on.
It is to say that there was a literature that attempted to explain these differences on the basis of genetic risk and on the basis of vitamin D deficiency. That literature really, although it hit the headlines, it really didn't provide much explanation at all. And in particular, the gene that was identified to increase South Asian risk was identified in the laboratory. Studies that were done in real life showed that gene was actually not an increased risk factor, and the evidence for vitamin D was just not existent. So what we basically argued was that there's a kind of life course history behind this, as well as cross-generational history behind this, that leads to making people much more vulnerable, ethnic minority people much more vulnerable in terms of infective diseases. And that led to the increase in mortality and, as you quoted, increased mortality risk for all ethnic minority groups, reflecting the marginalisation, the minoritization and the experiences of racism across ethnic minority groups. So, that white gypsy traveller, white Jewish people, as well as Black African, Black Caribbean, South Asian groups and so on.
James, do you know what I mean when I say the phrase triple threat?
I'm not sure I do, but
okay.
I've
so
kind
basically,
of used the term triple jeopardy.
So you're such a triple threat to government officials because you've got the receipts, but in a way, and what I mean by the receipts is the credentials that cover 3 key areas for holding government and power to account. You've got the science background, you've got the sociological background, and you've got the ability to merge the two and communicate them really clearly. And I'm just thinking of you personally, how frustrating the last few years must have been for you, because you've got people that are within both of those areas, whether it's medical sociology, whether it's medicine or sociology, that aren't necessarily converging the two and able to speak to what's happening as clearly as what you're doing. And then you've got the government that have just been doing a madness and just completely operating from a place of eugenics. So you're a triple threat because the way you speak about these things is so clear that it does very much hold government to account.
I would step away from the term eugenics because that implies something very conscious and deliberate.
Do you not think it's conscious and deliberate?
No, I think what's conscious is to not address inequality.
Right.
But that comes from a political belief that inequality is okay.
Okay.
And the health consequences of those inequalities, the health consequences of racism, are just a byproduct of wanting to deny the existence of racism and not wanting to do anything about the poverty in which certain groups of people are more likely to live. And so the deaths and the illness are in a sense a byproduct of these processes. But
I guess the reason why will think about this in terms of eugenics is because you literally saw decisions being made on the basis of age. These were purposeful decisions that decided who got to live and die on the basis of a category.
Yeah, so ageism in medical practice has been very obviously defined, identified and described previously in this question of age thresholds for treatment for cardiovascular disease, cancers and so on, I think have been challenged and well established. But one of the things that COVID pandemic did was to take agency away from older people.
Right.
So the response to the identification that older people were at risk, which was a delayed identification, then resulted in agency being taken away from older people. So if your parent was in a care home, he or she had no choice about whether they were going to see you or not. They were told they can't. So the ability to have agency to take risk in your life was taken away. But also, we do know that care homes were not protected in the way they should be, which is maybe slightly counter to what I've just said. Going back to the triple threat thing, I think one of the striking issues about the management of the COVID pandemic was the belief that this was following the science, and to a large
language, wasn't it? Following the science.
Yeah, following the science, and to a large extent, you could say they did follow the science, but they only followed one particular narrative within the science. So, as you said, there were particular types of people who were around the table. And so as far as I'm aware, there was only one social scientist who was present in those discussions. Economists were largely absent from those discussions. Sociologists certainly were. Psychologists were a little bit present, but not really.
But quote-unquote behavioural people, yeah.
So the people who were present were effectively infectious diseases, epidemiologists, and the mathematical modelers who worked with them. And that led to certain types of choices being made. Certain types of recommendations being made, rather than potentially others, which may have led to a more comfortable journey through the pandemic.
James, just humour me for 1 second, right? So currently, the date is the 7th of March 2023. It's 2 years since the pandemic now. 2 years.
3 years.
3 years.
3 years.
It's 3 years because we've lost. It's like we lost the year.
Yeah,
we
lost.
So it's 3 years, right? The reason why I'm giving the date is because over the past week we have been fed through the news media via Isabel Oakeshott WhatsApp messages exchanged between government ministers about the public messaging around lockdowns and COVID-19. As someone that has dedicated so much of their life's work to exposing ethnic disparities in health and medical sociology, like what is that like? Hearing about how awful these people are in power.
Really interesting is that these are the private conversations.
Yes.
So these are the conversations that will be unminuted.
Yes.
Prior to pandemic, when we were actually having face-to-face conversations, these were the conversations that would be unminuted and would be being held around a table. And so what maybe the content of the WhatsApp messages is not surprising. What's surprising is that these private conversations were held in a semi-public forum and then were made available to us so we can see how decisions are made. And that is a kind of, I don't know how to describe it. It's not a surprise, but it is shocking. Yeah,
I agree. It doesn't surprise me at all, but sometimes the transparency in which we're seeing inequality be discussed, do you feel like we're in a new era of that? Or is it evolved? Because I find it shocking. Then I'm like, no, I know that they think that there's a hierarchy of who
who should be a human being, basically. I do know that they think that, but equally when you see it, you're like, wow, you really do.
But racism relies on that hierarchy.
Yes.
As do processes related to class. They rely on the hierarchy of devaluing certain people compared with others. And behind that is an economic motive, of course. Yeah.
And just finally, James, where's the hope?
Where's the hope?
Yes.
The hope is hard, but I guess I am in some ways quite optimistic. And so I think the hope has come from the Black Lives Matter movement and its implication and its consequences. If you remember, at the time of the Black Lives Matter movement, there was a considerable rush for the leaders of a whole range of institutions, services to say, we will become an anti-racist organisation, or we are an anti-racist organisation. This was, of course, resisted, and that's where the Craig report came from. The Sewell report came from a resistance to that. But nevertheless, these institutions signed up to the idea of being anti-racist. The frustration, of course, is that they don't know what that means and how to set about doing that. The hope is that actually they can be helped along that journey. And so I've argued in various places that if you achieve change at an institutional level, then you can actually begin to address inequality. And just to illustrate that, if you think of the NHS and how many people it employs, if you think about the ethnic composition of the NHS, and then if you think about the NHS paying attention to inequalities in its workforce, inequalities in terms of the services it commissions, in terms of its place in communities, inequalities in terms of the way it provides its service to its customers. And if it puts racism at the centre of that, and addressing racism at the centre of that, then all of a sudden you improve people's lives in a whole host of ways, not just by giving them better healthcare, but also by giving them better employment conditions, and also the small businesses, ethnic minority-led small businesses that are around the NHS. You take that, and then you add to it education, and you add to it higher education, and you add to it local government, and then all of a sudden you can see a transformation. Now, this is a pipe dream, of course, but there are steps that we can begin to move along to get there.
If there was another pandemic, which is probably likely going to happen again in our lifetime, do you think that the UK government would respond differently?
I think the UK government would respond differently. I think, but not in terms of the question of inequality.
No.
I think it would respond differently because it cares about the economic consequences of the pandemic. And so it would try and do things to mitigate the economic costs of some form of pandemic control, which might mean stepping a little bit away from a full lockdown. I don't think it will care much about inequality, whether that's in relation to the age inequalities that we saw, or in relation to the ethnic inequalities we saw, or indeed the class inequalities that we saw during the pandemic. We could hope, but maybe this almost ground up process of addressing inequality might lead to change that I was talking about. Yeah.
Thank you so much, James.
Professor Laia Becares, thank you so much for joining us. This conversation now follows on from a previous conversation I had with James Nazroo about your work on COVID-19, ethnic minorities and health inequalities and racism, and it's so great to have both of you on this episode. And listeners will gather as Laia and I are talking now that there's a time lapse in terms of the gap between my conversation with James and my conversation with you. Conversation with James happened in March 2023, and now we are speaking today on the 30th of November 2023. And as we know, like the responses to COVID-19 are currently being I wouldn't say discussed, but are currently in the public forum via the public inquiry, and it just seems so. I'm glad in hindsight that we've had this gap between these two conversations, but it feels like even now we're learning even more about how ridiculous the response was to COVID-19. So anyway, that was a very long introduction, Laia, but thank you so much for joining us today.
Thank you. It's great to be here.
And just to kind of roll back, Laia, and think a little bit about your research and how you came to be doing this work, it would be great to give the listeners a bit of an introduction to you and how you came to be doing such important work.
Yeah. So I did my undergrad in psychology. And after that, I started working at Northeastern University in Boston, evaluating programs that were helping women who had who were abusing alcohol and other drugs. But those programs were targeted at Latina women. And so, yeah, they really focused away from the behavior and more thinking about their family context and how the system had taken their kids and they needed help bringing their family back together, and how they needed help with education and employment training. So I was working on that setting. And in those studies, I was seeing a really stark difference in outcomes for Latina women and African American women and white women, and how the system treats the same behavior very differently and criminalizes drug abuse very differently for white women and Latina women and African American women. And then I started reading around racism and the work of James Nazroo and David Williams. And at the same time, I was doing a master's degree focusing on neighborhood effects and really thinking about the neighborhood and thinking how deprived neighborhoods are really bad for health, but some deprived neighborhoods are also really cohesive. And so there's more than just the deprivation in an area. And so I put these two areas of thinking together to apply to the PhD with James Nazroo. So I moved to UCL to work with James, looking at neighborhood effects for minoritized ethnic groups and thinking about if we move away from deprivation and think about the people who live in these areas, the story is very different. So deprivation is really detrimental for health, but concentration of people is really protective of health. It brings social cohesion and social support, protects against racial discrimination. So that was my PhD. And since then, it had a really strong angle on racism and racial discrimination and how racism patterns area deprivation in neighborhoods and patterns poor health and all these other outcomes. And since then, I've been continuing to work on racism and ethnic inequities in health.
That's incredible. So you basically manifested working with James Nazroo. You were a student. You were like, this work is really inspiring me. I'm going to work with this guy. And you did.
Yeah, he did. Yeah, and the thing about James is, and you might not see this reading his papers and his presentations, but he is really a great mentor and an advocate for people. And when I applied to do my PhD, I had no funding, and he's like, well, how are you going to, this sounds great, but how are you going to do this? And so he was moving to the University of Manchester, which I didn't know. But in his move, I guess he managed to pull together funding for a scholarship for me, so a studentship. So my PhD studentship was funded by leftover money from James, who then moved to Manchester. And when I finished my PhD, I moved to Manchester. I was like, you're not escaping me. And then I did my postdoc in Manchester.
I love hearing stories about this between like-minded individuals, but also collaboration, and how much kind of care and support is so integral to us being able to produce important work. And it's so amazing for us as listeners to hear, well, for the listeners, but also me as an interviewer, to hear how integral that kind of relationship was between you and James, and then actually the product being such incredible interventions on a once in a generation kind of event. I see those things as going hand in hand, and it kind of brings me on to the work that you've done with James, what we heard from earlier in the episode, on COVID-19, health inequalities and racism. And I guess it'd be good, to just talk a little bit about where we find ourselves now in looking at the current situation.
No, but in terms of ethnic inequities, I think we find ourselves in the cost of living crisis, which is detrimentally impacting minoritized ethnic groups. But this builds upon the COVID pandemic, which was not just a health crisis, but a social and economic and political crisis, as we're seeing. And it's important to remember that the COVID pandemic builds upon the years of austerity that also detrimentally impacted on minoritized ethnic groups, the 2008 recession. And so this is a long-standing, persistent perma-crisis. And so at this moment, we have not built back better from the COVID pandemic, right? So we are moving into the cost of living crisis, or well in it. But in terms of COVID, I think, as you were mentioning before, the inquiry is, I guess, showing what we knew was happening.
Yeah.
But actually putting words on what we were, I guess, guessing, that the policy making was not up to par, perhaps. And we have been seeing the results of these decisions, but now we can see the conversations driving these decisions.
Yeah.
And how unfair they were. Yeah.
And like, obviously we've been talking about how disproportionately affected by COVID-19 ethnic minorities were. But I guess one of the things that I've been kind of surprised at so far in the inquiry, and obviously we're in the middle of it, so there's still more to come, but even the absence of conversations around ethnic inequalities in health outcomes from this inquiry so far. Like, we're talking a lot about there's kind of like a good versus evil kind of villain type thing happening. It feels like a very kind of public performance and display of, as you said, things that we were kind of guessing were happening. But I also like the absences are really clear for me as well. Like who is being spoken about, who is being mentioned, what is being focused on, and it does seem like the focus is on the malpractice of those in power, which of course is important, but it would be I'm yet to see a kind of emphasis on the victims. And I guess why I think that's interesting kind of from a sociological point of view, because it's like, even in our kind of quote unquote judgment of matters, of how policy is instigated, you still see power imbalance.
Yeah, absolutely. And I have to say, since you interviewed James in March and now in November, James and I wrote a report for the inquiry on ethnic inequities. Yeah. And he actually presented the evidence. And our report, and we were instructed to describe what was known when the pandemic started. So not how the pandemic impacted on minoritized ethnic groups, but what was known to that back, when the pandemic started, that policymakers should have taken into account.
Yeah.
So I think during the pandemic, during the inquiry, it's become clear that people didn't know what was going on and how to react, and decisions were made using different methods. But what in our inquiry, in our document, we show is that there was long-standing evidence of the existence of racism and racial discrimination, ethnic inequities in housing, in occupation, all these factors that we started to learn were closely associated with worse COVID prognosis and increased infection. And this evidence was completely disregarded. So I think early in the pandemic, we were able to say, there was all this evidence that you completely disregard. But speaking to your question about whose voices are heard and whose lives are not consistently brought to the foreground in this inquiry, I completely agree. But I think we have to remember that all these decisions that are made by people in power have detrimental impacts on sections of the population, for example, minoritized ethnic groups. Right? So even though it's not discussed implicitly, there's an implicit link between what was being decided and how this was impacting unequally on minoritized ethnic groups.
Like, you've just demonstrated to me and the listeners exactly the point, whose voice gets listened to, what gets taken seriously, and me sort of talking there. I'm kind of giving my kind of general public media overview of the inquiry, and then you're coming in and saying to me, well, actually, we did give evidence, but it wasn't listened to. And it's like we're just having an exchange in this moment, which shows exactly some of the things that are going on. Of course, I have a duty to be more informed on these things, but also the narrative that gets pushed and I guess it's also how hegemony or power remains in place, is one that is of performance and less about evidence. So it's so interesting, like, having this exchange with you in this way. And like, I guess for us as researchers and as sociologists, like, what do we have to do to get our message out there? I think you and James have done an incredible job with this research, and I think all the researchers at Code are so good at bringing information to publics, but there's obviously always more that we can do. And I guess going forward, like, reflecting together on these things is going to be integral, I think, going forward.
Yeah, I don't know if the evidence we provided for the inquiry wasn't heard. It certainly didn't make the headline.
That's what I mean. So when I say heard, I mean, like, I'm giving a kind of headline interpretation of the inquiry, which in of itself is a flawed is a flawed analysis. So when I say heard, like, that, and as well is structured around, like, so many different things. And yeah, I guess is interesting which bits are being picked up by the media and reported to by the public.
Yeah, and I guess we have to wait until maybe there's a final report by the chair of the inquiry on her decisions, and hopefully then she takes into account the evidence we've provided. But we'll wait and see.
Yeah, we wait and see. And I guess this is why, like, talking about something live as it's happening, like, it's important to do that, but also it doesn't tell us the full picture. And this is one of the reasons why we love podcasting as well, is because we can kind of do a critical overview as things are occurring. Laia, it would be really good to just kind of end on, like, where you see some of the hope when it comes to how we're addressing these matters and how we can get people to take seriously how much existing health inequalities are mapped onto existing social inequalities, and how we can get governments and people to take these seriously.
Well, in terms of hope,
yeah.
If we think about the COVID pandemic and how it started and the little information we knew and how the increased inequalities were being documented, and how there was a ground up movement with the Black Lives Matter initiatives that I think that really changed. And you can see a change from early pandemic to how institutions have co-opted this anti-racist decolonizing narrative. Whether then this results into action, maybe it's to be seen, and it will differ across organizations, but there has been a change. And the hope is that, for me, to see this change, again, changing narrative is not the same as changing action. So we have to wait a bit longer to see whether this actually translates into reduced inequities. But people continue to, for example, people at Code continue to work on this and continue to argue and publish and have conversations around the existence of racism. And again, in terms of hope, there was a big backlash to the CRED report, right? And so there was a big movement discrediting those statements and that work. So we continue to do work, highlighting this. Now in the cost of living crisis, also there's a lot of work being done highlighting ethnic inequities and pushing for policy making that addresses this. But
we
of course, this is
we continue to do it, don't we? It's doing the work, isn't it? And Laia, I said this to James as well, like, you guys that do the stats, you're a triple threat, like, and that's so good. Like, we need so many more, like, mixed methods, like quants and qual, like researchers and sociologists doing this work whose politics are ones embedded in anti-racist futures, because, like, there is a kind of power in terms of numbers and how data is produced and put forward to the public, and we're so grateful and in need of more Laias out there, because this is what we're going to need going forward, isn't it? And as you say, it's happening.
Yeah, thank you for the comment, but I also have to say that the statistics and how it's believed by policymakers, it's a double-edged sword.
Exactly, yeah.
The statistics are not neutral, and they can be really dangerous as well. And I think you may have seen the experimental statistics that ONS has published around mortality and ethnicity, showing that minoritized ethnic groups have longer life expectancy than white British people. So I think these findings, statistics, really support the evidence by the CRED report saying there aren't any inequalities, right? Because but these statistics are flawed, but they are really co-opted and believed by policy-making bodies. And so we always have to see what's behind the statistics and the methodological limitations of these statistics. And we are working now with ONS and with James and Laia and Sarah Stopford to try to reanalyze this data to show that actually minoritized ethnic groups do not have longer life expectancy than white British.
But but you, I guess, again, like you're like so brilliant at this. Like you're showing, like, to have that knowledge of being able to see when things are flawed. Like you said, it's a double-edged sword. Like that's why we need scholars like you and James, like, out there doing this work. Like that is the work and that's the contribution, and it's incredible. And yeah, I'm just really grateful that I'm around in a time where, yes, there's so much urgency around inequality, but like we're seeing people like you and James coming forward and saying, actually, we can show you how this is in fact not neutral and a flawed way of presenting data about people.
Yeah, thank you. And I think one important thing is that these statistics are driven by theory and an understanding of ethnic inequalities, which I think your podcast really contributes to.
Oh, Laia, this has been such an amazing conversation. I can't wait to have you guys on again, because we need this. It's something which I have I'm always a student of this work, and I know that listeners are as well. And this is really important knowledge production. And yeah, thank you so much for joining us today.
Thank you.
Thank you for listening to Surviving Society.
To support our work, you can rate,
review and subscribe. To host or produce a series of Surviving Society,
get in touch with us via Twitter or Instagram.